You're listening to Streetside, the Street Medicine Institute Student Coalition podcast. Hi friends. As Season 2 comes to a close, we want to thank you, our listeners, guests, and street medicine community for tuning in and listening alongside us as we explored stories from the front lines of healthcare for the unhoused. This season has been a powerful reminder of the impact of compassion in action. With only one more episode left this season, we're already looking ahead to an exciting Season 3, featuring deeper dives into advocacy, interdisciplinary collaboration, and new voices shaping the future of street medicine. Stay tuned and stay street smart. As you may or may not know, the 21st Annual International Street Medicine Symposium is being held this September in Hilo, Hawaii. And we're really excited to have the co-hosts HOPE Services Hawai'i for helping to organize the symposium. And it's really exciting this week because we get to listen to Drs. Michiko Fried and Dr. Kevin Emmons from the HOPE Services Hawai'i.
Excellent. So I'm Kevin Emmons. I did my undergraduate at Rutgers in New Jersey, and I did my master's and doctoral degrees at Drexel University, postgrad degree at UMass Boston. My work in my doctoral program focuses on symptoms and quality of life among people with complex wounds who particularly have advanced illness or fall into traditional vulnerable populations. So I've been a wound specialist for most of my career. I have full board certifications in wound care as well as foot care. And most of that time has been in that specialty of wound and foot care as a clinician. And I also have been a professor, and I was associate dean at Rutgers in Camden, 12 or 13 years. And then I came here to University of Hawaii in Hilo to pursue some opportunities at the university here and some community opportunities. So for the last 2 years, I've been an associate professor at the University of Hawaii at Hilo and collaborating with my partner here, Dr. Fried at HOPE Services. So it's a little bit about me, how I ended up here in Hawaii.
So grateful that he decided to come here. I remember meeting him at the university 2 years ago and said, "You are the answer." Because, well, for street medicine, it's just actually working with the individuals experiencing houselessness, period. Access to care is one of the most difficult things. Continuity of care is really challenging. And we live on a large, I don't know if you're familiar with the island of Hawaii, but it's large and rural and things are spread out and resources are lacking. So my name is Michiko, but I go by Michi, and I am a nurse practitioner with, I have my doctorate in nursing practice, family nursing practice. I started out as an ICU nurse. And I was born and raised and trained in California. So when I came to Hawaii, where my parents are both from, they're both born and raised on this big island. They're retired here now. I have a lot of extended family here, so very connected to this island. I decided to switch gears and go into primary care and into health promotion and disease prevention. I actually earned my doctorate at UH in the program that Dr. Emmons is teaching in right now. And unfortunately, I didn't get to have him as a professor. It was before he came. And then went into private practice, but always with an eye to working with individuals experiencing houselessness. When this opportunity with HOPE Services came up to integrate healthcare into a housing first organization, which is what HOPE Services Hawaii is, I just jumped at the chance. Our CEO, Brandy Menino, is visionary, innovative. We've been talking for years about how do you make this happen, and her persistence, I think, and her hard work paid off. I joined to help them set up medical respite program, and then I came on board full time as their director of health services to further develop the medical respite program, and then also work on reintroducing our street medicine program. It had been kind of on and off for a long time. And as you know, money dictates what we can do. So it was a matter of making sure that the funding source was consistent, that we had staffing that's consistent, and all of these things. I know we can touch on it later too, but these are the barriers in rural healthcare: staffing, funding, geography, just we just have a lack of resources. We are building out our, in addition to our street medicine and medical respite, our bedside care, where we have 7 shelters, various homes that we operate, try to serve all of the individuals within our system with one nurse practitioner and 1 RN right now.
One of the things that is, you listeners maybe think of, well, how did the two of you actually come together and pair? Because I think that's probably an important concept as we move through and answer some of these questions is, how do you get involved? How did you do what you're doing? And so we met randomly because she was teaching a course for us when I first hit ground, a clinical course. We were doing introductions, and I was explaining how in Camden I was doing wound and foot care, and I work with vulnerable populations, and how I do a lot of international work with indigenous populations. And Michi said, well, I have an idea for you. Is this what you want? I said, this is what I'm looking for. And so it happened fairly quickly that we connected. And I think that's part of the power of leveraging relationships, of using someone like myself who is in academia, but also practice, to then build that practice academia partnership with someone in the community who has those ties, and then we can build overall capacity. So ultimately, I think that just as we were deciding what are the roles, what does this look like, is that I was going to be here for a few years to help build capacity. And so, and ultimately a sustainable program. And so when I head back after I'm done my time here, and I can say, Michi, peace, I'm available via Zoom or a phone call always, but now you have the framework to then continue under the context of Hawaii and the ruralness of this island.
Yeah, setting up that foundation, giving us the framework, policies, ground rules, tools, even down to helping us set up our inventory, really streamlining the types of supplies that would carry us through, biggest bang for our buck kind of thing. It's just been an invaluable experience. We are so appreciative of having you here. We're gonna listen.
Thank you.
He's developed some great, just such strong relationships with a lot of the people that we serve on the street that, they look forward, they ask, hey, when's that doctor coming? Yeah, and so we're breaking it to them slowly, gently, letting them know. I know that one of the biggest advantages to this relationship is not only helping our team develop the skills and be able to maintain this level of care and to build upon it. He's been able to introduce these really strong skills within the people that we serve, strengthening their own, like empowering them, like strengthening their belief in themselves to be able to take care of themselves. And in teaching them, we've had the benefit too. We've had students, we've had volunteers coming along to observe this, and everybody is learning from this experience, because ultimately you can't be with somebody 24/7. The idea is to empower somebody to help themselves. And we have seen amazing progress in wound healing, in wound care, in self-confidence and self-esteem in the people that we serve, simply by taking the time and caring enough to take care of their wounds.
Thank you so much for sharing that introduction and for kind of getting into it a little bit. And I love the point that you made kind of about the balance of, having maybe like new personnel coming in and bringing experiences from different places and blending that with that essential understanding of the community and kind of how that is rooted. I know you kind of started talking a little bit about this, but I was hoping you could maybe give us a little bit more context about the current state of homelessness in your community I know you talked about like the rural kind of aspects of it, but any kind of policies that might be challenging for you, or any part of like the infrastructure that is particularly, a block for you right now?
Actually, I would say there are no policy or infrastructure barriers that I can identify. We have a governor who is very much supportive, trying to develop programs to creating housing. We get funding from HUD and from the state and from private foundations. This is very much, as a state, we're not the Aloha State for nothing. We definitely open our arms and really believe in helping the individual, meeting them where they're at and helping them. We have a very low barrier. We're a low barrier shelter. We are all about harm reduction principles, and trauma informed care. So when I think about what is systemically challenging, it's always going to be money and people. I think we can, if we want to get down to nitty gritty, we can start talking about, okay, well, what does insurance cover, right? I mean, but that's nationwide. That's not just our community. Like, where can we, but it comes back to funding, right? Where do we find the funding? Who's going to pay for these services that when you get down to on an individual basis, and there's somebody who has such great need, where does all of that come from? And so we have we have our programs that build up housing, and we have our Medicaid, insurance coverage. We have our EBT, right? So for food, we set up Social Security and disability. I mean, we have all of these things that everybody tries to provide. But when you have a lack of resources that maybe are going to address mental health conditions, or going to address substance use, or just something as simple as transportation, it comes down to money. We just don't have enough to serve as many people at the level at which they need it. And last year, so we had point in time count this year. I don't know what the numbers are, but last year we had over 1,000 on this island where we're considered houseless.
And for context, Hawaii Island is as big as all the other islands can fit in it geographically. So it's oftentimes known as the Big Island, but there are regions on the Big Island. I live on the west side, so to drive here, I have to drive through the middle of two volcanoes, about 7,000 feet in the air, and then back down. And so, it's very rural. You have these spots, little town hubs, but even those from each other are very far. And so you might have resources here in the hub in Hilo, which is kind of the main area on this island. But if you are far south, the ability to get to some resources can be very limited. If you're on rural northern coasts or up in the west, your ability to get access to care is really limited if you're not in the hub. So contextually, coming from the Philly metro area and in Camden, very urban in that area. But we also in southern Jersey have very rural areas, but it's much different than rural Hawaii Island. One, the cultural context is much different. So you have to come at it with this idea of cultural humility and being able to immerse yourself in the culture. And you don't have to know everything, but to spend time to listen and absorb and respect that is huge in any population that you go to. But especially here where there is such a large indigenous population that these beliefs permeate everything in this area. And so you have to be able to understand that to an extent, be respectful of it, or else you're going to be shut out. There's no, if you can't respect the cultural beliefs or the cultural understanding, even if it's not indigenous Hawaiian beliefs, just the cultural context of here on Hawaii Island and how we operate, things are a bit slower, literally slower to get things. It could take, a week to several weeks more to get things if you could even get them here on this island.
And COVID didn't help.
Yeah,
COVID didn't help. Also, just to add to that, when we think about indigenous cultures, there's so many different Asian cultures, actually, we have very strong population of the Philippines, from the Marshall Islands and Guam, the Pacific Islanders, Chinese, Japanese, Korean. So we have a lot of different populations living within these islands, and each one coming with their own cultural perspectives and practices. We are now also seeing more people coming from Mexico, and people are bringing their own practices and beliefs, and they're not necessarily subscribing to Western practices. We have a lot of turnover here in terms of providers, and so it can be discouraging to build a relationship with someone, to have that person leave and have to build it again. And then we are fragmented, so you might get your primary care in one place, but you would have to go elsewhere for your psychiatric care. And then you would have to go elsewhere for your psychotherapy, if that's even available to you. People get frustrated and get kind of lost navigating the system. And I know that's true everywhere. I realize that, but it's very much an issue here.
Yeah, thank you both for so eloquently giving us context on the situation there. I think it's really interesting you highlight, the need for resources. I like to think that everyone I've ever met who is doing street medicine is very resourceful. And so if you both could maybe talk a little bit about what's sort of like in your toolkit when you're going out on the street and talking with folks, I think that'd be really interesting to hear about.
Yeah, so I have the like conceptual toolkit and then the actual physical tool. So I guess I'll start with kind of conceptual toolkit of engagement and community trust building. And so I see, and this is where our relationship sort of spawned from, this idea that wound care being so physical, the physical manifestation of wounds, you can see them, you can smell issues, they're just in your face. And so people oftentimes seek care for things that are that visible, right? You may not know your hypertension is uncontrolled or that you have diabetes. We know millions of people walk around undiagnosed with conditions until there may be signs and symptoms that manifest. But with wounds and skin-related issues, those are manifesting themselves right away. And so it's hard to ignore them. And so using wound care as a bridge to build trustworthy bi-directional relationships with community members, to then ultimately introduce other services or to further provide social services, introduce housing, mental health services, using wound care, which is my focus, to build that relationship, to then use other tools to address their overall well-being. And of course, when I talk about wound care, I'm not, just talking about the skin-related issues. Obviously, there's, we address the whole person in that. Yeah. And so conceptually, in my toolkit, that's what I see myself as, kind of this bridge of building relationships, trust, and then introducing other services. Once they say, oh yeah, I know Kevin, or I know Dr. Michi, they can help you. And I can't tell you in the past year alone, how many times we've been able to help people just from trust alone. So they know, well, we can call this person, or we can reach out to that person. Oh, Kevin will be here on Wednesdays, so they get more people to come around to a certain area, and then we can continue to build those relationships and expand. And so I think conceptually in my toolkit, that's how I see my role as this bridge, providing services that are obviously well needed, but then to open the door to Michi's toolkit in some things that you can talk about.
We have specialists and directors who are in charge of housing here. We have an outreach team, and they make the initial connections for us. And our outreach team has always been an integral part, like a foundational part of HOPE Services Hawai'i. They are the connection to the community. And what they do is identify individuals who might be in need of any kind of health care, but primarily, as Kevin was saying, wounds, because people want their wounds treated. For the most part, we have some exceptional stories, but once we have somebody on the list, then we know whom to target when we go out, because we have only limited number of hours, because again, resources, right? We have limited number of hours where we can go out. We might start with wounds, also the overall like comprehensive health, and meanwhile, trying to get a feel for their perspectives on housing. Not everybody wants to be housed, So definitely by building those bridges that Dr. Emmons was referring to, we have been able to reassure people that housing is a good thing. That they can be in a place where they can trust it, they can feel safe, that it's going to be beneficial to them. It isn't for everybody. Once we make the connection, they realize that they can trust what we say and that we are going to do our best to follow through to meet their needs.
Such a beautiful perspective. Thank you. And what I found so interesting about a lot of the tensions that you've spoken about in terms of earning trust, I think everyone who's in the street medicine space has interesting stories surrounding this. But you both have kind of mentioned, really interesting kind of perspectives on, maybe Eastern versus Western medicine, indigenous beliefs, which I think may be more unique to your region. I was wondering if you had any stories that you think of that kind of resonated with you, patient stories that you would like to share with us.
I mean, we could talk about, things like diet is very important here and very important in any culture, really. It's a way to interact with people and family. But regarding topical wound care, we worked with someone who was collecting flowers, types of leaves to use for moisturizing. Right? So in our area, we're in a very tropical area. There's actually, I think, like 13 of the world's climates on this island. So we can look at snow while also be 100 degrees, while also be raining every day. So being in a tropical environment where Hilo is, being able to utilize and understand that there can be a kind of a pluralistic way to approach one thing. So let's say somebody has an autoimmune disorder. So we'll use a person that we know has autoimmune disorder, who didn't have access to topicals that we would normally use to reduce inflammation. But what they were using for a long time was certain leaves and flowers to rub on the skin to have the oil seal. And so for me, it would be very easy to say, don't rub leaves on your skin. Like that's not going to help you. But that's not going to help the person that believes in that. And which actually, most of our medicine comes from, traditionally plants and we learn from living things and then redevelop. And so for me, I could take a pluralistic approach of yes, you can continue to do that and make sure it's clean, but you might need to seal it in. So let me give you something that would then seal that particular thing in. When I first came here, I spent several weeks with a traditional healer to learn how to use different plants and what were the roles of, creating eye drops from this one flower or ingesting this other for digestive health. And so being able to recognize what people are saying, I'm doing this, it's very paternalistic to be like, don't do that, right? But if we know that it's been used and it's fairly safe, how then do we integrate that into that pluralistic idea in which we can integrate Western and traditional thoughts? The good thing about wound care is 90% of it's like non-pharmacologic, right? So some of our products, you could chew on and it's not dangerous because it's made from seaweed or other products. And so I can kind of convince or, provide education to people say, this product is pretty natural. This is a seaweed product. Are we able to integrate that in with what you're doing? I want to absorb the drainage. You can put whatever you want in the wound, use a salve from a flower. Some honey. So it's understanding what traditional medicine is for them. And again, as Michi said, there's really a melting pot of not only just indigenous beliefs here, but other indigenous cultures as well as cultures around the world.
Yeah, I love that you went and met with a traditional healer and sort of learned the context of that. I think that's really interesting. And, I would love to hear sort of what both of your North Stars is for, working with these marginalized folks and sort of like what has drawn you to be in this career working with this population.
So I think mine has been from a place of service, of just always, I was brought up in and around Camden, New Jersey, so I know what it's like to be poor and to not have. But my mother raised us by herself, while her children, and always instilled in us this idea that we always have to serve other people, no matter where we were in our life journey as a family, whether we barely had plumbing or didn't have money for whatever it was still this idea of service. And so I've always carried that through, and not service in most traditional sense of volunteering here and there, but what can we do or help or facilitate for just those around us. So knowing that it's not selfless, it's about giving yourself. And so from that, I really learned and understood about health disparities and the impact on inequities. And so that kind of created this guide for me, really ever since 20 years, I guess it's been 20 years now that I've been in nursing and healthcare. And so I was able to integrate that idea of service to others, but really understanding what, that there are inequities. Like, why does your zip code determine when you're going to die or what diseases you're going to get? And so, I always just think about like, what's my role in that? But it's very important that I think about, it's not, my role isn't like I'm not there to do things to other people. It's not about the me. It's about learning from others and what their needs are and how do I integrate within that? How can I become a part of that community? How can I become a part of your life? How can I become a part of your care plan? And it may just be showing up one day a week and talking for 20 minutes.
My mother's family plantation, my father is coffee farm. So a long history of poverty and hard work, but what they always had was each other. What they always had was community, sharing and giving, and what we call gaman, which is enduring, has always been, it's just part of my culture, my family, my understanding of how the world works. It's one thing to be poor, and it's another thing to have inequity in your life. When you need something, where do you get it? How do you get it? Who helps you? Right? So a big part of what I've always believed in, my North Star is community. When I look at the people around me, it's going to be, well, who are you? How can I get involved? It's the same thing. That's why I was saying it's going to echo a lot of what Kevin was saying. How can I be a part of your life? How can we be a community together?
No, I think that mindset both explains a lot of the work that you've done, and I guess that kind of leads us to our next question about what advice you would give to individuals that are working with people experiencing homelessness or honestly entering any sort of service fields.
What students, and this goes for any volunteer, I'm just using a student as an example, is they're always thinking, well, how am I going to give? And I always have to flip that narrative, and guess what? It's not about you or not about me. And you're going to very quickly learn you should be pulled in and feel what's being felt in that community by understanding, right? You can never truly put yourself in their place. We can be empathetic and say, I hear you, I'm with you, but to be in someone else's shoes is very different, very difficult, and impossible. So what you have to do is just come at it as an area of selflessness. And so it's just not about you. And so anyone volunteering, it's not, I'm going to be the savior and I'm going to go, save everyone. If you come at it, you will fail, guaranteed, because guess what? It isn't about you. And people will pick up on that real quick, that you're just here to put another star on your ribbons or another award or whatever it is. It really has to come from a place of selflessness, whether you're a volunteer, whether you're going to get paid. Yes, you have a job, but if you wake up every morning and you're like, I don't know why I'm here working with this population, whatever it may be, then you're not going to last very long in that, because it has to come from a place of selflessness. Everyone needs a paycheck too, don't get me wrong, but this may not be the field for you. So you have to be able to say, it's not about me, more so about the community, others, piece of advice. And then my second piece of advice, build bridges, don't be in a silo. You cannot be successful in this field, or really most areas, if you build walls around yourself or you practice within a silo. And there's several reasons for that. One is, there could be duplication of services happening. Is what you think you're going to do even that important to a community, right? If you were functioning out of this idea of just me or what I want to do. And even with working with organizations, how connected is that organization, or how do they broadly see the community? Does it align with your philosophy and beliefs? And can you create bridges? Can you create relationships? So you have to be able to, a people person, You may not know everything, but if you can build relationships, that's a starting point.
And you don't act like you know.
You don't act like you know everything. Yeah. So you have to be able to give up I, and you have to be able to communicate to build bridges. Don't be by yourself.
I agree with Kevin. If you can take the I out of that and look outward, always look outward and say, what needs to be done here? And ask, who are you? What are you thinking? What are you feeling? What do you need? This idea of I'm going to save lives. I ask nursing students and nurses, what is it that you want when you say you want to help people? What does that mean? Can you define it? Because there's a lot of glamour sometimes tied to nursing that people think they're gonna come and perform these interventions and people are going to be so grateful. And that it's going to be a well-paying job. And I say, no, actually, let me show you how when you're working with a person and you take yourself out of the picture, it's not glamorous at all, right? It's about sometimes very raw, difficult and emotional. You have to be careful to take care of yourself as well in your own health, because you can also get discouraged easily or frightened or maybe too involved. I ask people, check your baggage at the door. Try not to bring too much of your history, your bias. Evaluate your own biases. That's so important. And I think people forget that. They come and saying, oh, I'm not judgmental. I don't judge people, but you see it all the time. And I said, that's in all of us. We're all judgmental, but do you realize that you are? And is that impacting how you are assessing the situation? And is it going to influence the kind of care that you give? Because it's really important to say, no, that, this actually is a problem for me, or I have difficulty with this type of a situation. Okay, well, maybe I need to ask some questions. Maybe I need to get some help and evaluate this further before I make a decision about what to do next. None of us can do this alone. And we've already said so many times in different iterations is we have a lack of resources. So we depend on our community partners. And we have 3 main hospitals and 3 access hospitals, 1, 2, 3, and 3 critical access hospitals on this island, and they're spread out all over the place.
And very small.
Anyone who's trauma one has to be medevaced to another island. And so I remember when I was doing some per diem ICU nursing at one of the hospitals, and somebody had a hemorrhagic stroke, and he was unstable and couldn't be medevaced. And what they did was they called the family in and to say their goodbyes. Whereas if you had been in an urban setting, that person would have just been transported right to a hospital that could have helped him. And I remember that vividly, thinking, wow. And the family accepted that, right? But I knew somewhere else. I worked in a hospital where they would have had neurosurgeons on this in an instant, not here, right? Calling them family in to say goodbye. So, that was an eye opener coming from California, Southern California, where our industry. We want to engage family, engage our community. We're trying to raise awareness on a island-wide scale, on a community level scale, public health, population health scale, right? Of we're all in this together. It's not a me, you thing. I get to enjoy my home and all the luxuries that I have because I made the right choices, or I did something right in my life, or I deserve this and that person is there because they deserve that. No. Right? We're trying to break those barriers down. We all make mistakes. We all have flaws. And also, please don't complain unless you have a solution. Like, please don't expect somebody else to fix something if you're not willing. And that goes back to, why don't you just volunteer? If you really have a concern or a complaint, or you just don't know, we're happy to educate you. We're happy to bring you along and say, this is a very human experience. And there, but for the grace of God, go I. We've had lava flows, we've had hurricane floods. We just had a fire in Maui. They don't discriminate. They don't discriminate. People have been made homeless, have suffered, have died. It had nothing to do with how much money they had in the bank. It had nothing to do with, what their educational background was. And we have in Hawaii a growing population of older adults. They are less able to care for themselves as they age. They don't have strong family support because of our economy, and they're young, their families moving to the mainland or even moving off of the island to Oahu, right? To have a life of their own. And now they're aging, their houses are in disrepair. I can't tell you how many people have come to us because they've been found having fallen in their homes and down for 1 or 2 days, and they just happen to have a neighbor who cared enough to go and check. And they're in the hospital now, and they can't go back to that home. It's not habitable. It's inhabitable. And what did this person ever do to deserve this, except to grow old, right? And so what is your path to houselessness? And why, and how can we help you to lead that a life of dignity and comfort and just meet your basic, the basic human needs, make those connections, because who wants to be lonely and sick? And nobody really. So also don't categorize people. We get that impression that those homeless people, right? No, everybody is different, which is why we go back to what is that path to homelessness? Who is this individual? What makes them unique? Why are they where they're at right now? And stop lumping people together and judging people. But true compassion is coming within a
discussion I had 2 weeks ago with a colleague in New Jersey. She said, Kevin, gosh, that's really, awesome work you're doing. Man, that's wonderful. She was really glamorizing it. And I was like, there is nothing sexy about, hiking through a rainforest in mud, falling over with a flashlight at night, trying to find people.
in the rain.
Not glamorous. Like, you have to really, really want to do it to be out there,
Yeah.
schlepping along bags.
And still calm, smile. Actually, that's not hard. We don't seem to have a problem showing up calm and smiling. But let me tell you, when we get back to the car after mucking through the rain and the mud and smelling like unusual smells. We had one student who had to leave the scene because she was going to vomit. Not because of the individual, just the area. I mean, the area itself was pretty ripe. When you think about it and you take the humor out of that, somebody is going through that every day, right? Somebody has chosen, that's why actually we emphasize housing. We say, this place is not healthy for you. Can we please move you somewhere where you still have your independence, right? But it's clean, it's safe, you can feel better. And you deserve to feel better, right? You deserve to have a safe, clean place to live. Because sometimes people feel like this is all they're entitled to. And that's important to vet out sometimes too. Like, what does this place mean to you? Sometimes there's a connection. Actually, we had somebody who refused to come to shelter because he actually owned a piece of property. We've had a couple people like that. They actually own a piece of property, but that piece of property is like that. That's what it is. It's a mud and rain soaked place with overgrowth and no lighting and no plumbing, but it's theirs and they don't want to leave it. Yeah, I had someone who was able to get into a home, and he was able to get into a home on a piece of property But the other services that he needed, this was before we even had street medicine. This is before I was a part of HOPE Services and street medicine. But this also lives on in my memory. He was put in a place, but without services, wraparound services. And nobody was addressing his alcoholism. And it's so easy to be disconnected from a person if you don't have to meet with them every day. Again, that's why the consistency with knowing people and meeting up with them on a regular basis, but this was way back when. And he was found, dead in this home one day after having been there like that for days because nobody had checked in on him. And that lives on in my memory. So knowing the person, their personal struggles, I can't say it enough. It's not piecemeal. You're not just treating a part of a person or a thing of it. We're not just treating homelessness, or as Dr. Emmons was saying, we're not just treating a wound. We're treating all of the reasons why this would happen, right?
Yeah, there's this geeky saying, so don't treat the hole in the patient, treat the whole patient. And I love that. It's so geeky, but it works well.
So geeky.
That's great. No, I love that. That's a great line. I might keep that for the header or something. Thank you both for making the time to chat with us. Just really to close off, is there any sort of way or any sort of thing that you want to plug so that people can learn more about your work, maybe support it?
Yeah, well, HOPE Services Hawai'i. Log on to our website, figure out ways that you can contribute, because we will never say no to money. But also, if you really want to learn something, reach out, and we're happy to talk to anybody. We're happy to present. We accept volunteers in any way, shape, or form. We have something for everybody, because this is your community. And we're all in this together. We are one. We are an ohana. We say it all the time. We talk about living with aloha, and we would like to think that here at HOPE Services Hawai'i, we do that every day.
And if you're interested in building academic practice partnerships, you can reach out to me via email. I'm sure you just Google Kevin Emmons Wound Care and it'll pop up wherever I'm at it. But it'll be at Rutgers. Yeah.
Amazing. Thank you both so much again for sharing your story and giving us a lot of context on the work that you're doing with HOPE Services in Hawaii. I think it's really inspiring and very empowering as someone who is literally about to do a street outreach event tomorrow. So thank you so much.
All right, you too. You take care.
Thank you so much.
Yeah.
Bye.
For transparency, this episode was recorded 2 years ago. Thanks for listening. As always, if you have any suggestions, comments, or concerns, please feel free to reach out to us using the email in the show notes.
The opinions expressed in this podcast are those of the individuals included and are not representative of the opinions of the Street Medicine Institute or the Street Medicine Institute Student Coalition. Do not use this podcast as medical advice, and instead see your own provider for medical care.